What are the unmet needs is, of course, we should educate surgeons to do the correct operation. That's one thing. So not only removal of the cancer, but also thoroughly look at the lymph nodes, for example. So we know that when you obtain a real R0 resection, according to the criteria by the International Association of the Study of Lung Cancer, which have been published already in 2005, when you obtain a real R0 resection with a thorough lymph node dissection, you get the best prognosis. And some data have shown, it was a paper of John Edwards some years ago, that when you have what is called an uncertain resection, so meaning that the surgeon thinks everything has been removed, but for example, not an adequate lymph node dissection has been performed, that your survival will be poorer. So that's one unmet need, to really educate thoracic surgeons, especially in smaller centers, to do the correct operation. And I think the second one is to look thoroughly also at staging and educate surgeons about how to do precise staging. And in some cases, we will need not only PET-CT scan, but also endobronchial ultrasound as a phageal ultrasound, or even mediastinoscopy to have correct staging of the mediastinum. And the third point I want to mention is that we need to incorporate surgery within multimodality treatment. Probably not for smaller stage 1 lesions, but stage 2 and 3, to look at the combination not only of surgery, but also neoadjuvant versus adjuvant, chemotherapy, chemoimmunotherapy. We have a lot of questions about that. Or should we do it perioperatively, giving as well induction as adjuvant therapy? So I have many questions around that. And we know that operating after induction therapy, be it chemotherapy, immunotherapy, or combination, can be quite tough for the surgeons due to hyalofibrosis and inflammatory reaction around the pulmonary artery that occurs.